So it's with great pleasure that I introduce Joanna Arch, who's a professor in the Department of Psychology and Neuroscience at the University of Colorado Boulder. She's a psychologist by training, and her work, as you'll hear about today, focuses on understanding and developing interventions for anxiety, stress, and coping in patients with cancer. And you'll hear about some of her approaches that involve acceptance and commitments-based therapy, as well as other exposure-based behavioral interventions. And among the many reasons I'm excited for her to present today is that one of the, as Joanne and I were talking about a little bit a couple of minutes ago before everyone logged on, is that there's often silos based on diseases, and the way the NIH funds research, it's often disease-based as opposed to trying to get outside those silos and seeing what's common across intervention developments. We can really develop more generalizable, scalable approaches. And so I'm really excited for everyone to hear about the work she's been doing with cancer survivors, and hopefully we'll have some time for discussion to think about interventions we're developing for patients who've had cardiac arrest and heart attack, strokes, and some of the other conditions that we've been working on in the Roybal Center already. And Joanne, you'll see we have a really diverse audience signed on today that includes, scholars at different levels of their training. We also have some people who have experienced some of these events themselves or as family members. And yeah, so you'll get some really nice feedback on your work, I hope.
Thank you. I am humbled and honored to be here. I absolutely love your center. And I have to say that not only are the people who I've met incredible, but you have an amazing name, Fearless Behavior Change. Wow. I feel really inspired to pursue my own fearless behavior change by virtue of simply putting that out there in the world as a title for your center. And I love the work that you all are doing in the cardiovascular space. So I am here today, and feel free to jump in at any point. If we don't get through everything, that's totally fine. Although there are a few studies and that I may skip to if we end up running short on time. Today I'm here to talk about acceptance and commitment therapy and exposure-based interventions for distressed cancer survivors. And let's jump in. Hopefully my slides are working. There we go. So what is our roadmap for today? I'm giving you guys a nice view. I think this is New Mexico, so our neighboring state here in the Colorado Plateau. So I just want to put out there, what I'm trying to do in this work, because I actually trained as an anxiety disorders researcher with ACT and CBT and exposure therapy in the lab of Dr. Michelle Krask at UCLA. And I only got into psycho-oncology work about 12 years ago by happenstance, because my husband, who is an oncologist, and I hated oncology until that point because I had to hear about cancer all the time from him. And I found it really depressing. He introduced me to a clinical social worker in his practice group, who also has a PhD in medical anthropology. Her name is Dr. Jill Mitchell. And we had like a mind meld and just had a real synergy. And she is the one who encouraged me to start doing work in this area. That was back in about 2011 when I first started out on the tenure track as an assistant professor. And so since then, Jill and I still collaborate, and a lot of this work is thanks to her. So our psycho-oncology research program leverages behavioral science to help adults with cancer and significant fear and anxiety to suffer less and live full and meaningful lives. This work mostly has taken place in the US, but I also have a collaboration now in Nairobi in Kenya, where we are trying, because in many parts of East Africa, cancer is like the new epidemic. And there's a lot of need for psycho-oncology really all over the world. A lot of the best work in this area is actually happening right now in China and in Iran. So this is work that's really needed in many, many parts of the world. And then I love this quote from Dr. Paul Kalanithi. Some of you have probably read his bestseller, When Breath Becomes Air, about his journey with lung cancer. And he says, even if I'm dying until I actually die, I am still living. And now those are really the words that inspire my work, particularly in metastatic cancer, which I will talk about in the second half. So, just a little bit about me. I really have three main lines of research. The first is laboratory and treatment research on anxiety disorders and stress. I still have a whole research program actually treating social anxiety disorder. It's community-based participatory research. I'm not talking about that today, but that is really fun work that I've been doing really my whole career since, you know, the beginning of my independent career in 2010 and then also in graduate school. And then since 2011, 2012, I've been doing treatment research with distressed cancer survivors, particularly those with elevated anxiety and trauma. And then I will not have time to talk about either the purple or the orange today, but I also do a lot of work on cancer adherence behaviors. And Dr. Kronich, you are familiar, you've seen me present on some of that work. So let's talk today about treatment research with distressed cancer survivors. I'm going to be giving you snippets of a bunch of different studies. So I'm not going to go into a ton of depth on any of them, but I am happy to answer questions. And this work really spans two different populations. The first being distressed adults with early stage cancer. So here we have, somebody who could be a cancer survivor of early stage cancer, and she's done with treatment. And treatment was done with curative intent, meaning that they expect her to be cured of her cancer. And there are lots of different questions that come up for cancer survivors. The first, because cancer is like the C word, societally speaking, not just in the United States, but in many countries in the world, cancer is associated with death. And so it can really shake people up existentially. And they can ask, who am I now? My friends and my family don't get it. My community doesn't get it. I should be doing more, right? Because often people feel very fatigued after cancer treatment, probably similar to lots of cardiovascular events. I can't keep up at work. I'm exhausted. I have brain fog. I feel abandoned by my medical team. I used to see them every week for treatment, and now they're like, see you in 6 months. And I feel like, oh my God, who's going to support me during that time? And then, really, the number one source of anxiety and fear for cancer survivors, and this is particularly true, well, it's particularly true, it varies a bit by cancer type, but the biggest fear is recurrence. What if this comes back? And cancer does recur to varying degrees depending on the type of cancer. It can have a very high recurrence rate. So as an anxiety researcher, when I first started getting into this work, I turned to this really beautifully done meta-analysis of 275,000 people out of the UK by Dr. Alex Mitchell and colleagues. And this is a meta-analysis. This is an old meta-analysis at this point, but the findings have been similar more recently. These are folks who are a decade or more after cancer treatment. So these are early stage survivors, 10 or more years after cancer treatment. And you can see with the red line there, on average, cancer survivors, long-term cancer survivors, have elevated anxiety levels relative to controls. And what's interesting is that depression tends to resolve within a year or two after finishing treatment, but anxiety appears to be the long-term legacy of cancer. I'd be curious if that's also true in heart disease and stroke. You all know that, I do not. So as mentioned, anxiety is common. It tends to be chronic, and it is typically unaddressed concern among cancer survivors. It often co-occurs with depression and depressive symptoms, but anxiety alone predicts lower quality of life over and under use of medical care, depending on the study and what type of healthcare we're talking about, and depending on the meta-analysis, possibly earlier cancer recurrence and death. The reentry phase is where I started this work. The reentry phase is probably very relevant in some of the diseases that you all work in too. It's that phase where you're done with treatment and now you're being sent back out to your normal life, your regular life. And that transition is very anxiety provoking for many patients. They kind of power through cancer treatment and it doesn't really hit them until they're done what has happened, and they're then left kind of picking up the pieces without the support of their medical team at that point. So my first research aim in this space was to address anxiety among cancer survivors at reentry. And of course, as intervention researchers, we have to ask which intervention makes sense to use for a specific set of challenges. And like I said, I have done a lot of clinical trials with exposure therapy, with ACT, with CBT through graduate school, through postdoc and early faculty years, and still now. And so I was really curious, why I kind of concluded that ACT would be the best match, but the question is why? So why ACT for anxious cancer survivors at reentry? And I'm just going to walk you through some pieces of evidence, many of which were gathered in my earlier work. The first is that we showed in my early work on ACT for the treatment of anxiety and trauma-related disorders is that it's a particularly good match for broader emotional distress. So for folks who are both anxious and depressed, and that is a common clinical profile in the immediate aftermath of cancer care. Where both of those tend to be elevated among the third to half of folks who have elevations in mental health symptoms. Second, we know that the efficacy evidence base is good. So ACT effects are durable over time. We followed people for up to a year in my early work. But then we get to some really important things, which is that particularly in cancers that have a high rate of recurrence or in metastatic cancer, our patients are facing realities that they can't fully change or influence themselves. Sure, you can eat well, sure, you can quit smoking, sure, you can exercise more, but sometimes even that's not enough. Cancer, like many diseases, can have a mind of its own, and it can be out of our control. And I think an acceptance-based model is a particularly good match for that really challenging context. And then last but not least, as I showed you with the hypothetical cancer survivor at the beginning, cancer really opens up a lot of existential concerns for people. Death concerns come up very frequently, even in early stage cancers. And I think that ACT is a model that's well equipped to handle those. So the answer to that question, which intervention to choose, ACT provides a close conceptual match between the nature of the problem and the nature of the intervention. In that an acceptance-based stance that also allows people to explore their deepest values, I think is a good match for what often gets triggered when we get diagnosed with cancer. And then ACT provides a well-matched empirical foundation in terms of the moderator and the efficacy evidence basis, at least based on the work that I've done previously. So this is the classic ACT hexaflex model with the 6 points on the hexaflex. And I'm not going to go over these in depth. I'm happy to answer questions afterwards. But in essence, one half of the model are acceptance and mindfulness-based processes, and that really focus on actively accepting whatever is present internally in a given moment, and then relating to thoughts and beliefs more flexibly so that they don't get in the way of moving forward in valued areas. That process is called diffusion. And then there's also this values-driven behavior change processes of clarifying who and what you most care about. Those are our values. And then committing to behave in ways that align with those values. That's called committed action in ACT. How many of you are familiar with ACT, by the way? You raise your hand. I can see at least a few of you. Okay, so good. And it's good that I didn't spend a lot of time on that model. Now I know that your center knows this model very well. Dr. Lisa Unken's NIH STAGE model I know is core to a lot of the work that's done at centers like yours. And I love her model. I've been using it for years. And so I'm just going to walk you through how I've used this model to start this work. So first, of course, is intervention, generation, and refinement following basic research. And in the traditional research model, we have the researcher on top saying it's my ideas that matter. And then we have patients and community practitioners listening to us, right? And it's like this real hierarchy. And because my work started in the community, because my husband is a community practitioner, my sister, I only have one sibling, she's a stroke neurologist, she runs a stroke center as a director in the community in Southern California. So I am surrounded by community practitioners who left academia to take care of patients. And so I had started this work with a community practitioner, Jill Mitchell. And so I really have taken a different stance in my work. I work a lot with community practitioners, particularly clinical social workers. I listen a lot to patients. We always do tons of focus groups. We do systematic feedback after every intervention session. We do exit interviews, and I feed all of that feedback back into the interventions that I do. And I've been doing this since the very beginning. So all of the work that you're going to see here, especially in early stage cancer, involves that. So what does that look like? So I come to Jill and I'm like, you know what? Our ACT for Anxiety model, it's 12 to 15 sessions, individual therapy. I can totally adapt that for your anxious cancer survivors. And she looks at me and she says, number one, we're not allowed to do individual therapy. We're social workers in a community oncology center. We don't have time. It's not in our mandate. And number two, we only run groups. And the maximum our groups can be are 6 or 7 sessions, and they have to meet on site. And so I'm like, okay, that's the parameter in which I need to work then. I need to do a group intervention. It needs to be no more than 6 or 7 sessions. And it needs to be led by the social workers themselves, not by me and my students or like people I'm hiring in from the community. And I have to train them in like a day, and then use ongoing supervision because they don't have more time than that. So, um, so that's what we did is we adapted ACT, a very long ACT protocol for a 7-week weekly group that was led by Jill and I in this pilot study, and later by the other social workers. This was a single arm trial, and you can see here across multiple baselines, we see no change. And then following intervention, we see big drops in anxiety and depression. Effect sizes are down here. And we saw similar for trauma symptoms and for fear of cancer recurrence symptoms. And so I thought, okay, we have some signal here. So then instead of going into research clinics, what I love so much about the NIH stage model is there's a solid line that allows you to go straight to doing efficacy trials in the community. And that's exactly what we did. We got an R01 level grant from the American Cancer Society, and we ran a trial in the community using community oncology social workers who had no background in ACT other than Jill as our interventionist. So what did we find? I'm going through these very quickly. I'm not going to give patient characteristics for everybody, et cetera. But these were older adults in Colorado, so they were like 85% white and 15 to 20%. Our largest minoritized community in Colorado by far is the Latinx community. So what did we find in this early trial with about, how many was this? About 135 patients. We found that even though we screened for anxiety, it was really folks with higher baseline anxiety that we improved the recovery trajectory for. These were anxious cancer survivors at reentry, so they had finished treatment within 2 years, within a year or two, and we sped up their recovery by doing ACT relative to enhanced usual care, which was giving them resource lists of available resources in the community. But what we've also found is that for folks with low baseline anxiety, they recovered no matter what. These slopes are significant. They're going down to almost no anxiety over a 6-month follow-up period, no matter what they get. And we saw something similar for experiential avoidance at baseline. So folks who are high in experiential avoidance, they benefited. These are anxiety outcomes I'm showing you here on the HADS-A scale, which was the scale that was used the most commonly at the time. I actually really don't like that scale, and I have not used it since because I don't like the items. I think they're outdated. But anyway, nonetheless, we see significant declines in the ACT group over time for folks who are high in baseline experiential avoidance. But if you're low in baseline experiential avoidance, everybody gets better over time. And we don't beat enhanced usual care, which is interesting. Across the entire sample, trauma symptoms improved more in the ACT condition. So that was nice to see. Everybody's getting better, but the ACT condition is getting better and getting better faster. And then we had them track missed medical appointments because I'm a behaviorist at heart, and we validated them against the EMAs, against the electronic medical records, EMR, and we found that in the ACT condition, folks missed fewer appointments. Nobody was missing a ton of medical appointments, but nonetheless, the ACT condition was missing fewer, which was nice to see because that alone probably paid for the intervention. So just to give you a sense of the patient voices, this participant said, the intervention offered me solutions and tips to deal with depression, anxiety, and fear. It helped me restore my lifestyle and reclaim my dignity. With the focus on values and committed action in ACT, people got different things. So this person felt like it helped them to build stronger relationships with family and friends. This person said it helped them understand new ways of dealing with thoughts without succumbing to them as an excuse for not moving forward. So in summary, most anxious cancer survivors recover. These are early stage cancer survivors, stage 0 through 3, solid tumor cancers across types. We treat across types. Why? Because that's what's done in the community. So I wanted to just focus on one cancer type. Nope, not possible in the same way in the community. So again, community practitioners are always influencing my work in really profound ways. So most anxious cancer survivors recovered over time following cancer treatment, but Group ACT accelerated their recovery, particularly for our more anxious and avoidant patients, and it included reductions in missed medical appointments across the whole sample, which was nice to see. All of these groups were led by on-site clinical social workers with minimal ACT training. It was super important to have an on-site study champion. So Jill's my on-site study champion. She's absolutely amazing. She was the only one of the 5 social workers that had any background in ACT. So the efficacy was probably down because they were super new to the intervention, but wow, it really boosted our external validity. So let's talk, so that gives you a sense of some of the work I've done in early stage cancer. I still really love that population and would love to continue working with them. But currently, and in the recent last few years, my work has focused increasingly on folks with metastatic cancer. And again, there's a patient-driven reason for this. In that early pilot work for the early stage ACT work I just spoke about, we allowed a few folks with oligometastatic cancer in our groups. That's metastatic cancer that is only kind of minimally metastatic. And so those folks tend to live quite a long time with metastatic cancer, but nonetheless, they told me that they really liked the ACT intervention, but they felt like it just wasn't for them. They were like, you know what? I know I'm going to die of my cancer, and most of these folks are never going to have cancer again. And that makes me really different. And I don't feel like our concerns are quite the same. And I thought, wow, you're right. And they said, please do something just for us. These were community patients who told me this. And so I took that as a cue. And fortunately, the NCI and the NINR, the National Institute for Nursing Research, had gotten really interested in palliative care. And so I kind of rode that in applying for these grants. So again, I had to start back at stage 1 because I didn't really know how to treat, how to support folks with fully metastatic cancer. Because these are the kinds of things I was hearing, which is really different than what you hear in early stage cancer. This is a parent with metastatic cancer who says, I know this cancer is going to kill me, but I'm not sure which I fear more, having to take a drug every day that makes me feel terrible forever in order to stay alive for as long as possible, or dying. And these are the kinds of choices that people with metastatic cancer face every day. And then there's even harder things about metastatic cancer. This is a grandparent. She says, I know I'm going to die from this cancer someday, but I have to keep on fighting because I'm the only stable adult in my 2-year-old grandson's life, and I'm in charge of my care. His parents can't care for him. His parents were addicted to substances. The thought of abandoning my grandson is. So what I want to point out here as an anxiety and trauma researcher is that these are rational fears, right? Often, like when I was trained as a graduate student to treat anxiety disorders, what you do in CBT for anxiety disorders is you're like, well, what's the worst case scenario? How bad could that be? Like, couldn't you deal with that? And this is this grandmother saying, I know what the worst case scenario is, and I can't deal with it. It's unacceptable. So I think this calls, again, it's hard to use a classic cognitive therapy approach with concerns like this. And so again, I found myself back with an ACT intervention model. And so I just want to walk you through a series of studies that we've done using ACT for adults with advanced cancer. Our aim was originally to enhance psychological well-being, but I met with the president of this community oncology network that I work with in Colorado. It's the largest in the state, and it's part of US Oncology, which is probably the largest provider of cancer care in the country. They treat 1 in every 4 or 5 patients in the country. And I met with the president of Rocky Mountain Cancer Centers, who at the time was Dr. John Flagel. And I said, Dr. Flagel, I'm thinking about doing this work in advanced cancer to improve anxiety and depression. And he looked at me like a classic medical oncologist. And he's like, okay, mental health is all good, but what about something concrete like improving advanced care planning? Because like these folks are going to die of their cancer, and we often don't know what they want at the end of life. And most of them aren't telling us, and we really need to get on this. So could you please look at that? So again, it's the community practitioners telling me what to do. So I thought, wow, I don't even know what advanced care planning is. I better learn about that. So I did. And so we target in this work anxious or depressed adults with metastatic cancer, but we also target not only their mental health, we also target their behaviors, their engagement in planning for future care if they can no longer speak for themselves. And we also figured that, you know what, we think 7 weekly groups is a lot for this population, especially in person. So we're going to move about half that content, about 40% of that content online into self-paced online modules. But we know people who are just sent off to do an app, especially middle and older age adults, who's most of whom we work with, are not going to do it. They may not even have the tech skills. A lot of our folks are low tech literacy who we work with. So we decided to alternate online self-paced modules that they do at home themselves with the group. And so then every week in the group, we report on how many group members, we don't say who, but we say, like, oh, it's so great. Almost all of you did the online module. Those of you who didn't, like, tell us what you need support with. So we use the group to hold them accountable to doing the online, because otherwise they don't do it. Understandably, I don't do it either. I've tried taking online courses and I don't do them either. So it's not just our older adults. So this multimodal intervention where we do self-paced modules alternating with groups builds on evidence that provider contact boosts online intervention response rates, and some work actually in your city that adults with, and at your university, that adults with advanced cancer can respond better to group versions of an intervention relative to individual versions, because advanced cancer is a highly stigmatized condition, and it can be very empowering to meet other people who share your medical diagnosis and prognosis. So here's what our group online modules look like. This is the home page, just to give you a sense. We try to make it super colorful. We have 3 modules that they do in between the groups. We have daily check-ins. We try to make them really fun. So this is a daily check-in. Some of you are familiar with the passengers on the bus metaphor and act. So this asks, what value directions did you try to move your bus towards today? There's more values than just these, but these give you a sense of kind of what we're working with. They click on one of these, they state like what they want to do that day that moves them in that value direction. We follow up, we say, did you do it? What got in the way? If you didn't do it, that kind of thing. This is another daily check-in where they can practice skills at home that they learn in the online modules and kind of reinforce in their daily lives. So what did we find? We did a single arm open pilot trial in this space that was published a few years ago. It's very hard to move these outcomes in metastatic cancer because folks are getting sicker over time, and they were really sick. We had people vomiting in cups in group. So this was a quite ill population. And nonetheless, we managed to move over time anxiety, depression, sense of meaning, fear of dying outcomes. We did not move pain outcomes, not surprisingly, because their cancer was getting worse. But look at this, Dr. Flegel is right. We were able, by talking about advanced care planning, to improve advanced care planning. And so that became the primary outcome in the NINR R01 that we are in the process of doing now in community clinics, again with social workers leading our groups from these community clinics. So this is the study protocol for the trial that we're doing now, the NINR R01 supported trial. And we have enrolled 225 of our 240 patients. And that was almost all during COVID. They kicked us out of the clinics. We're not allowed in the cancer clinics anymore because we can't risk giving COVID to immunocompromised people. So we've done all this recruitment virtually, which is challenging, but possible. And advanced care planning engagements are our primary outcome, but we also are asking really important questions like, what is the relationship between mental health symptoms and people's ability to engage in advanced care planning? We actually don't know. We have no idea what the answer to that question is. So at baseline, when people tend to have higher or lower anxiety and depression, does that mean that they are more or less likely to be engaged and have done some component of advanced care planning? And then over time, as we improve their anxiety and depression, do we also, what changes first, the mental health symptoms or the advanced care planning engagement? We're going to hopefully be able to get you some answers on that. We're also looking at group differences in those mental health outcomes, and we're looking at ACT hypothesized mechanisms of active acceptance and aligning behavior with values. So stay tuned, that's going to come out soon. And then I was just telling Ian that in the past month, we got an R01 to follow up on this trial in ovarian cancer, in advanced ovarian cancer, which is really exciting. This is funded by the NCI, but the original work was funded by the National NCCN, which is a National Cancer Comprehensive Network, and AstraZeneca. And you'll find out why AstraZeneca was interested in this. So there was a huge revolutionary breakthrough treatment for women with advanced ovarian cancer who have genetic mutations, BRCA or RAD mutations. Those women were the first to die originally. They had the most aggressive forms of cancer, and now in many ways, they are the luckiest because these PARP inhibitors, which is this new class of medication that's used in all kinds of cancers now, but the original FDA indication was for ovarian cancer, work exceedingly well with these women, and they live years longer, which is amazing. However, PARP inhibitors cause extraordinary fatigue for a lot of the women that take them, not unlike many of our best medications across any field of medicine. So we did an MPI, a multiple PI study at Harvard and at CU. Alexi Wright, who's my primary collaborator, is a gynecologic oncologist at Harvard's Dana-Farber Cancer Institute. She recruited me to collaborate with her on this study. Hannah Kapoor is now back in the Netherlands, but she was at Harvard originally. She's a really awesome fatigue researcher, fatigue and cancer, and Alexi obviously is a ovarian cancer expert. We did an adaptation. They had me adapt ACT into a telehealth intervention to target fatigue. Now, I needed Hannah's help here because I had never targeted fatigue in an intervention. And we targeted fatigue in 40 women with advanced ovarian cancer who were taking these PARP inhibitors. So how did we target fatigue? What did we target? We do an individualized assessment in the first telehealth session with each of these patients, and we assess the following areas that we think from the literature are contributing to fatigue and making it bigger than it needs to be. So a PARP inhibitor will always cause fatigue for most people. So our goal is to shrink it back to what the medication causes. The medication caused fatigue, not to have it grow and grow to become bigger and bigger by being disconnected from loved ones, community, in other words, who and what you most value, doing too much or too little, so poor pacing of activities, getting hooked about thoughts of cancer, so rumination and worry, which is really draining physically and mentally, getting hooked by thoughts about this chronic fatigue you're experiencing from your medication, and then sleep problems and poor sleep hygiene, which, wow, did we see a lot of sleep problems stemming from chronic fatigue from the meds. And so what we target in this adaptation of ACT for fatigue, for medication-caused fatigue, is we target sleep, normalizing sleep, pacing activity properly, connecting with values and values activity, value-based activities, and unhooking from thoughts about fatigue and cancer. So not that those thoughts aren't normal, but we just don't want them to get into a ruminative cycle around that really drains the precious energy they have. And so this is the kind of materials we worked with. This is from Auntie Act, who unfortunately she passed away this year. So this is in honor of her memory. She made these originally for Russ Harris's famous book, The Happiness Trap. He's a famous ACT author. And we use metaphors like the struggle switch. So you don't want the fatigue, you don't want the anxiety, you don't want the anger, sadness, frustration, and guilt, right? And if you struggle with having all of those things all the time and try to push them away or get rid of them, that takes all your precious energy that you still have. And so we try to get them to turn their struggle switch off and say, here's anxiety, I don't want it or like it, but I'm not going to struggle with it. So I developed meditations like acceptance of fatigue meditations, where they sit there and they open up to the sensations of fatigue and they allow themselves to experience those sensations without trying to get rid of them, asking themselves things like, is this really so bad? Can I really not live with this sensation? And really befriending the sensations in a different way. So there's a large mindfulness component here too. And here was our pilot data. So our primary outcomes were fatigue related. So this is interference of fatigue in daily life. We saw large effect size differences by follow-up. In that, medium to large incurrent fatigue, medium effects for self-efficacy that revitalize the ACT condition is in red here. And we saw significant differences in quality of life measured by the FACT. So that was really nice. And then based on these data, we had the only perfectly scored R1 that I have ever had. We had a perfectly scored R1 that we just got the notice of award for a few weeks ago. Thank God. So now we are going to be able to do this on a larger scale. And before I forget, one of the aims on that R1 is to follow up on these awesome findings from the pilot RCT, which is that in enhanced usual care, we saw more dose reductions of the PARP inhibitor over that 3-month follow-up period. These are blind medical chart reviews. And we also saw more dose delays of the PARP inhibitor over time, I think because it's just such a hard drug to tolerate for so many women. And if you don't have a way to cope with that fatigue, you might consider quitting the drug, understandably. So that was really exciting to see. And we're chasing down that finding in the ART1. And then, you know what, we did a bunch of exit interviews where women talked about just accepting the fatigue, living with it, living their life in the best way that they can with it. And here's somebody, you know, cancer is knocking on the door, but it's actually been helpful to embrace my life as it is because you can be joyful with what you have. So you can really see that acceptance piece at work here. So this is that next step. This is the MPI trial that Alexi and I are about to launch. So stay tuned. So a parallel line of research, I became through doing all this work on ACT. ACT is what I would call, in that telehealth fatigue intervention, we made it a bit narrower. But I consider ACT to be a pretty fat-fingered intervention, meaning that it affects a lot of things. And I became a little bit concerned that maybe it wasn't hitting certain outcomes as hard as I might want it to because it was doing so much at once. It had such a radically transdiagnostic focus. So I became really interested in trauma symptoms. And as an anxiety researcher, I became really interested in people's imagined horrible futures that they were imagining with their metastatic or advanced cancer. So I, in parallel to all this other work, started developing a novel line of research on adapting exposure therapy to address advanced cancer-related trauma symptoms. And this original work was funded with a competitive internal pilot grant from our cancer center. And I'm submitting an R1 to follow this up in June. So I became really interested in this idea of worst case cancer scenarios. So with your metastatic cancer, what's the worst case future scenario that you're imagining? And you might say, why would you want to work on that? Every MD I told that I was doing this thought that I was crazy and they thought it would never work. And they could have been right. That's why I had to test it. So worst case scenarios, WCSs, to me as an anxiety and fear researcher, represent the apex of anxiety, fear, and anticipated trauma and loss in serious disease. So I became really interested, if you want to be efficient in intervening on anxiety, fear, and trauma, why not go for the jugular? Why not go for the most intense version of whatever it is you're trying to treat? Because we have really limited time with these folks. And so I was also hearing from folks on our R1 that we're wrapping up now, that we're in the last few years of, in metastatic cancer and anxiety and depression and advanced care planning, that people don't have a lot of opportunities to process or talk about their worst case scenarios because families and providers are often dismissive. Who wants to hear about your loved one's worst case scenario, especially if it involves saying goodbye to you at the bedside of hospice? Like, that's a horrible thing to think about. Providers want to keep patients focused on, you know, treatment. Families want to keep them focused on positive thinking. And so often our patients feel incredibly lonely and often rejected when they go to talk about their fears, especially their most intense traumatic fears. And what we know for people who are already distressed is that avoidance of our deepest fears and sources of anxiety typically intensifies fear over time. And in fact, in some of this early work I cite here, it is hypothesized, and there's pretty good evidence that it actually triggers and maintains anxiety and trauma disorders. I may be preaching to the choir here, but worth noting. And so I decided I really wanted to tackle these worst case scenarios. There was a little study that came out of Canada in this space that seemed promising in early stage cancer, but I wanted to do it more comprehensively, so I developed a novel approach to addressing these worst case scenarios called EASE. I'm terrible with acronyms. This is a terrible acronym, but EASE stands for Written Exposure-Based Coping Intervention. And it is a procedure, a systematic but very simple procedure to help folks face their deepest fears while activating their strengths. And you might say, well, how do you do that? What we did is I trained a number of years ago in one of my favorite interventions of all time, which is written exposure therapy for PTSD. It's Denise Sloan and Brian Mark's baby from the National Center of PTSD in Boston. I think Denise is one of the most systematically thoughtful researchers in the intervention development and testing space working in the US today. And I learned that treatment and I decided to adapt it to address worst case scenarios in advanced cancer. And Denise was, consulted with us on this work. But I want to just give you a warning. I do not work with cancer survivors. I work with really distressed cancer survivors. The majority of humans can get a cancer diagnosis, even an advanced cancer diagnosis, and not be clinically distressed. I'm working with like the 30 to 50% who are really distressed, and in this case have elevated trauma or fear of progression, using evidence-based cutoffs. So I would not use this with just anybody. So what does this intervention involve? So in the first session, and this was through trial and error, we treated 30 patients with this approach. And this evolved over time. So the first thing we do is identify their worst case cancer scenario. That takes a whole session because often people know that they're terrified, but they have trouble getting down to what their deepest fear is. So we kind of use at session 0 to do an assessment of that. And then in sessions 1 through 3, they write in specific ways about their worst case scenario. And then in sessions 4 and 5, they evaluate the likelihood of their worst case scenario and how they would cope with it. So this is actually pretty different than Denise Sloan's original intervention. In the first 3 sessions, we have them write for 30 minutes in about the concrete details of their worst case scenario as they imagine it right now from the beginning, writing in first person, present tense, as if the situation was really happening in the here and now. And that's to enhance vividness and emotional processing. So these are kind of the instructions. We have them write about their deepest thoughts and feelings and their 5 senses experiencing. So what they see, smell, hear, etc. They have them write about the event as if it has a beginning, a middle, and an end. This work was just published this month. And then in sessions 4 and 5, after they've done that for 3 sessions and we coach them on how to do it, because often they can't do it for a session or 2. So often they only have like 1 session where they're really doing it in the way we want them to. In sessions 4 and 5, we say, do you think that your worst case scenario is likely to happen in exactly the way that you've written about it? If not, write about why it's unlikely to happen and why it won't occur in detail, and then what's more likely to happen and what you can do now, if anything, to make that better case scenario more likely for yourself. Again, integrating your deepest thoughts and feelings, etc. And then if they really do think their worst case scenario is likely, and some of them really do, and I think they're right, how would you cope? And who would support you? Exactly what would they say and do? How would they help you? And if you need more support than what you already have, how would you seek it for yourself? And what would your goals, priorities, and values be in dealing with that worst case scenario? And what could you do, if anything, now to reduce its negative impacts? Because often the worst case scenario is saying goodbye to loved ones, etc. So I was shocked. The MDs, like I said, the MDs in my life thought I had lost it doing this intervention. But look at this. This was the world's easiest intervention to enroll in. My graduate students were therapists. They had no background in this. I trained them in 2 hours. It's very easy to learn. And people really liked it, shockingly. 26 of the 30 completed all 5 sessions. And we saw really quite large, these are large effects. I think at 3-month follow-up, this is a D within group D of 1.15 on cancer-related trauma symptoms. This is fear of cancer progression. All these folks had advanced cancer or incurable blood cancers. We see depression, anxiety, which I'm not showing here, hopelessness about cancer going way, way down. which was super awesome. But of course, this is single arm data, which I never fully trust until we get that randomized trial data in. But what are our kind of overall takeaways? So stay tuned because I'm applying for an R01 this June to follow those findings up. And I think the big problem with getting that study funded is that unless you're a behavioral scientist, you really think that that approach is crazy. I mean, to have people face their worst fears in metastatic cancer sounds nuts to a doctor. I've yet to meet a doctor for whom they do not think that's crazy. And they do everything they can in their power to not go there with their patients. And here we are like, bring it on. Nope, I don't think that's scary enough. Nope, I think your worst fear is actually more than that. It's like totally against everything they learn as physicians. So I totally understand why they don't like it, but we'll see if we can get somebody to fund it. So ACT is a transdiagnostic model, just to summarize this work, to tackle diverse challenges in the context of cancer, including mitigating anxiety and depression, increasing engagement in future healthcare planning, reducing treatment-related fatigue. I didn't get to this work today. Ian has seen me present on this, on increasing adherence to oral anti-cancer treatment. I've used this model. It's a very flexible model. I think it's a really nice match for seriously ill populations. But we also have this adaptation of written exposure therapy, which is promising to reduce trauma symptoms and fear of disease progression, surprisingly acceptable, surprisingly easy to learn, at least preliminarily, and is transdiagnostic, I believe, in that it's relevant to many different disease types. And where I want to take this work next is to caregivers. I was talking to Allison Applebaum, who some of you may know. She's in New York City based. I think she's at MSK. She runs the country's only cancer caregiver clinic. And she was like, Joanna, every meeting I have with cancer caregivers is about the worst case scenario. That's all we talk about. And so I think there's a real potential here for cancer caregivers, for dementia caregivers, and Alzheimer's and beyond. You can tell me if it's relevant for cardiovascular folks or not. And then again, importance of designing for dissemination. I collaborate very seriously with community practitioners. I train and use non-ACT experts in all of my intervention work, and I try whenever possible to embed trials in community settings and to use technology realistically. I am not going to tell 60, 70, 80-year-old cancer survivors, much less a 20-year-old cancer survivor, oh, go put this app on your phone. It's going to cure all of your problems. It just isn't, and they're not going to use it. And frankly, I wouldn't either. So I think we have to be really realistic about how we use technology. And just to end on this idea that this work would be completely impossible without community practitioners and the patients, and I am forever grateful for them enabling and really informing this work in very deep ways. Thank you.